Hello friends, welcome again to the series of continuous cardiac education organized by UN Mehta Institute of Cardiology and Research Center, Ahmedabad. I am Dr. Mrugesh Prajapati and I am going to talk about the hemodynamic waveform analysis and artifacts. So as all we know, hemodynamic waveforms are very important part of our day-to-day professional life, and the thorough knowledge of it is very crucial for better management of the patient. So not just the number on the screen, but our interpretation of the waveform is very important. So today I am going to talk about the hemodynamic waveform analysis of invasive arterial blood pressure, central venous pressure, pulmonary artery pressure, and the intra-aortic balloon pump pressure. So first we talk about the invasive blood pressure monitoring, which is gold standard for the surgery where you expect major fluid shift or the blood loss, or surgery of the aorta, surgery requiring the cardiopulmonary bypass, and any surgery where you need more accurate and beat-to-beat pressure measurement as well as frequent arterial blood sampling. So what is before going to the waveform of the hemodynamic waveform, we just see the basic principle of the pressure monitoring system. So the basic principle of the pressure monitoring system consists of the column of the fluid directly connecting the arterial system to the pressure transducer, where it get converted into the electrical signal, and this electrical signal then processed, amplified and converted into a visual display by microprocessor. These are the components of the invasive blood pressure monitoring system. Here we can see the arterial line is placed into the radial, and the site of basically the site is decided depend on the nature of the surgery. So the arterial catheter is connected to the pressure transducer via the saline filled non-compressible tubing. The transducer is also connected with the monitor and the pressure bag and the automatic flushing system. So basically the pressure transducer converts the pressure waveform into the electrical signal. These are the component of the pressure transducer. So understanding of the physical principle helps us to interpret the waveform better and to reduce error. So what is sine wave? A wave is a disturbance that travels through a medium transferring energy but not the matter. The simplest form of the waveform is known as a sine wave. So these are the component of the wave, and the maximum displacement of the wave from the zero line is known as the amplitude, and the number of the cycle per second is expressed in form of the hertz. Any complex waves can be broken down into a number of the different sine wave. What is Fourier analysis? So the process of analyzing a complex waveform in terms of its constituent sine wave is known as the Fourier analysis, and the arterial waveform is clearly not a simple sine wave, but it can be broken down into the series of the many component sine waves. So here you can see two waveforms. One is a blue line which is a fundamental wave, and red one is a second harmonic wave. The summation of this waveform make the typical arterial wave, arterial pressure waveform. So what is the property of the pressure monitoring system? So mainly it includes the natural frequency and damping coefficient. What is natural frequency? Natural frequency is a system. Natural frequency of system determines how rapidly the system oscillate after stimulus, and damping coefficient is basically frictional force acting on the system, which determine how rapidly it returns to the rest after stimulus. So now the another part is natural frequency and resonance. If a force with a similar frequency to that of the natural frequency is applied to the system, it will begin to oscillate at its maximum amplitude, and this phenomena is known as the resonance. This is the famous example of resonance. You may be aware about this example. They were in 1850, the Anger Bridge, which was the suspension bridge, get collapsed due to the effect of this resonance. The battalion of the soldier passed through this bridge with the similar frequency that of the natural frequency of the bridge, and the bridge started oscillating and ultimately get collapsed. Same principle will be applied to our pressure monitoring system also, and if the natural frequency of monitoring system is too low, the pressure waveform will overlap that of the measurement system, and the system will resonate, and pressure waveform recorded on the monitor will be exaggerated or amplified, and then the true intra-arterial pressure. So it is important that the invasive blood pressure system has very high natural frequency, at least 8 times to that of the fundamental frequency of the arterial waveform, which is pulse rate. So therefore the system to remain accurate at heart rate of up to a 180 beat per minute, its natural frequency must be at least 20 Hz. Most commonly available system have natural frequency of 200 Hz, but it can be increased or decreased by various maneuver. Natural frequency of the system can be increased by either reducing the length of the cannula, reducing the compliance of the cannula, reducing the density of the fluid, increasing the diameter of the cannula. Contrary, the natural frequency can be reduced by addition of the three-way tape, bubble, clot, or additional length of the tubing. Damping is also important part of the pressure measurement system. What is damping? It is anything that reduces the energy in an oscillating system will reduce the amplitude of the oscillation, and it is termed as damping. Some degree of damping is required in all systems, which is known as the critical damping, to prevent any overshooting. But if it is excessive or insufficient, the output will be adversely affected. These are the example of the under damp or the overshooted arterial waveform, and this is the under damp arterial pressure waveform. So in case of the under damp arterial pressure waveform, the systolic pressure is falsely high, the diastolic pressure is falsely low. Ultimately the pressure pulse pressure is very high compared to the normal waveform, and in case of the overdamped arterial pressure waveform, the systolic pressure will be falsely low, the diastolic pressure will be falsely high, and the pulse pressure will be low. How can we diagnose whether the pressure monitoring system is underdamped, overdamped, or optimally damped? So there is a fast flush test or square wave test which is used to test the dynamic response of the system. So here we can see that the normal arterial pressure waveform, and if in such scenario we activate the fast flush valve, then it will produce a square wave on the monitor followed by the 1 to 2 oscillation, which followed by the normal arterial waveform. It is a optimally damped waveform. So here there is no any adjustment is required, and the pressure showing on the monitor is actual. So in case of overdamped system, the waveform are overdamped, and if we activate the fast flush valve, then the square wave will be produced, but there is a slurred upstroke or downstroke, and it is not followed by any oscillations, followed by the again the overdamped waveform. In such scenario, we have to check for the presence of any blood clot, air bubble, or kinking of the tubing, and we have to rectify it for proper measurement of the pressure. In case of underdamped waveform, the activating the fast flush will produce the square wave, but it is followed by the multiple oscillation, which is known as the ringing or fling, and again it will followed by the overshooted waveform. In such scenario, we have to either use large bore cannula or shorter tubing, or we can use the damping device to rectify this error. Fast flush test is also important to measure the natural frequency and the damping coefficient of the system. Natural frequency is calculated by the dividing the paper or the screen speed by the wavelength. In this example, the paper wavelength speed is 25 millimeter per second, and the wavelength of a wave is 1 millimeter. So natural frequency would be 25 Hertz. For damping coefficient, we have to take the amplitude of the two consecutive resonant wave, which is calculated by dividing the smaller ratio by the larger. The respective damping coefficient is then taken from the chart shown here. If the damping coefficient is less than 0.7, then it is an underdamped system. If it is more than 1, then it is an overdamped system, and if it is 1, then it is a critically damped system. The another important aspect of measurement of the invasive pressure is zeroing and the leveling of the pressure transducer. So basically atmospheric pressure must be discounted from the pressure measurement by the transducer, and it is done by exposing the transducer to the atmospheric pressure and calibrating the pressure reading to the zero. Leveling of the transducer is also important, otherwise it will show the falsely high or falsely low pressure, and we should keep the transducer just 5 centimeter below the sternum, which correspond to the aortic root. Practically we keep the transducer at the level of the fourth interposal space in the mid axillary line. If the transducer is too low, it will overread, and if the transducer is too high, then it will underread the pressure. Now let's come to the waveform, normal arterial pressure waveform. So as here figure shows, the component of the arterial pressure waveform include the systolic upstroke, peak systolic pressure, which is followed by the systolic decline, dichrotic notch, which suggests the aortic or closure, followed by the diastolic runoff, and its end with the end diastolic pressure. Here if you compare this wave with the ECG, there is a normal delay of around 180 millisecond, and this delay is because of the actual ventricular depolarization and the arrival of the signal to the pressure transducer. The shape of the arterial tracing is mainly affected by the stroke volume as well as compliance of the arterial system. So these are the example of the compliant arterial tree and the non-compliant tree. If we compare the waveform of the young with the adult patient, then in older individual with reduced arterial compliance, the early return of the peripheral reflected wave will distort the smooth upstroke with the early systolic hum, produce a late systolic pressure peak. It will attenuate the diastolic pressure wave, and it will increase the pulse pressure. If we go from the aortic root to the periphery of the arterial tree, then the waveform will also alter. If we compare the aortic arch waveform with the femoral artery waveform, then in femoral artery waveform the arterial upstroke will be delayed, systolic peak increases, the dichrotic notch will appear later, the diastolic waveform become more prominent, and end diastolic pressure decreases. We have to also consider about the arterial pressure gradient in case of the aortic coarctation of aorta, thoracic and abdominal aortic surgery, and when we use cardiopulmonary bypass. If we use cardiopulmonary bypass, the mean radial artery pressure decreases on initiation of bypass and remain less than the mean femoral artery pressure throughout the bypass period, and it will persist for first few minutes following the separation from the bypass, often by more than 20 milligram mercury. Here we can see after initiation of the bypass, the radial artery pressure is decreased compared to the femoral artery pressure, and after 30 minutes of post bypass it will return again to the similar to that of the femoral artery pressure. Let's see the arterial blood pressure waveform in different pathological condition. If we see the arterial blood pressure waveform in aortic stenosis, the upstroke and downstroke will be slurred, the pulse pressure will be reduced compared to the normal arterial blood pressure. In case of the aortic regurgitation, there will be a dual notch or a pulsus by variance. In case of the HOCM, there is a peculiar spike and dome configuration of the arterial waveform, and after correction it will have normal arterial blood pressure waveform. In case of the LV dysfunction, we can find the pulses alternus, where there is a alternating beats of the larger and smaller pulse pressure, and in case of the cardiac tamponade, we can find the pulses paradoxus, where there is a marked decline in the both systolic blood pressure and the pulse pressure during the spontaneous inspiration. The arrow shows the variation during the spontaneous inspiration. The arterial blood pressure waveform also help us to detect the intravascular volume of the patient. The cyclic variation in the systemic arterial pressure is known as the systolic pressure variation. The normal systolic pressure variation is 7 to 10 millimeter of mercury, and hypovolemia causes the dramatic increase in the systolic pressure variation. Another dynamic marker of the preload reserve is pulse pressure variation. Many automated devices are now available that provide real-time pulse pressure variation. Pulse pressure variation should not exceed 13% to 17%. In addition to systolic pressure variation and pulse pressure variation, more sophisticated pulse counter method allow measurement of the stroke volume variation also. Normal stroke volume variation is approximately 0% to 13%, whereas greater variability predict the positive response to the volume expansion. Now let's look at the central venous pressure waveform. The CVP waveform basically consists the A wave, C wave, V wave and X and Y decline. Let's see how these different components are generated in CVP waveform. So, if we look at the cardiac cycle, during the end diastolic period, when the atrial contraction happen for the late filling of the ventricle, the atrial pressure is increased and it will produce the A wave. If we compare it with the ECG, it corresponds to the PR interval. We suggest the atrial contraction produces the A wave. During the early systole, when there is isovolumic ventricular contraction, the tricuspid valve will motion toward the right atrium. It will increase the right atrial pressure and produce the C wave. During the mid systole, when there is a systolic collapse of the right ventricle, the tricuspid valve will come down, the atrial pressure will decrease and it will produce the X decline. During the during the late part of the systole, when there is a systolic filling of the atrium, the pressure of the atrium will again increase and it will produce a V wave. And in early diastole, when there is a early ventricular filling, then it will produce the Y descent. So basically, when the atrial pressure is increased, it will produce a positive deflection on the CVP waveform, and when the atrial pressure is decreased, it will produce the decline. Let's see the CVP waveform in different abnormal condition. So in case of the atrial fibrillation, basically there is a loss of the atrial kick, so there is a absence of the A wave. The C wave will be prominent and the V wave and Y descent will be preserved. In case of the isorhythmic AV dissociation or the nodal rhythm, the retrograde conduction of the nodal impulse throughout the atrium causes the atrial contraction to occur during the ventricular systole, while the tricuspid valve is closed. It results in the cannon A wave. Here you can see the early systolic cannon wave by the which is marked with star. If we do ventricular pacing, then it will produce the systolic cannon wave. But if we convert it to the AV sequential pacing, then the normal waveform will be restored and the arterial blood pressure will be increased. In case of the tricuspid valve regurgitation, there is a tall systolic C and V wave and there is a loss of X descent. In this example, the A wave is not seen because of the AF. In tricuspid stenosis, where the passive filling of the ventricle is hampered, so the diastolic Y descent is attenuated and the contraction of the atrium occur against the closed or stenotic tricuspid valve, so the CVP will be increased and the A wave will be prominent. Let's see the pulmonary artery pressure waveform. So pulmonary artery catheter or the Swan-Ganz catheter was introduced in routine practice of the OR and the intensive care unit in 1970, and it is very helpful in basically those patients who have low cardiac output. So in procedure of the pulmonary artery catheter insertion, when we insert the pulmonary artery catheter into the introduction sheath and we reach 20 mark on the pulmonary artery catheter, we have to ask the assistant to inflate the balloon. So when the catheter tip is inside the RA, it will produce the waveform of the CVP, like that of in the central venous cannulation. When we advance this catheter into the RV, the systolic pressure will rise, the diastolic pressure will be same as that of the RA pressure, but when the catheter advance into the pulmonary artery, the systolic pressure will be same, but diastolic pressure will come up, and when it so the base pressure, it will be same like the CEP waveform. When we deflate the balloon, the waveform again comes to that of the pulmonary artery pressure waveform. When we compare this all wave side by side, you can see here that in right atrium the waveform are similar to that of the CEP waveform, and it has all the component like A, C, V wave and X and Y decline. When the catheter is advanced into the right ventricle, there is the systolic pressure will be higher than the right atrium, but the end diastolic pressure are almost equal. When the catheter advances into the pulmonary artery, there is a diastolic step up compared to the ventricular pressure. In case of the wedge pressure, the morphology is similar to that of RA, although the A and C and V wave are appear later in the cardiac cycle relative to the ECG. This is the comparison of the ECG, CBP and left atrial pressure or the wedge pressure. Here we can see there is a delay in the different component of the wedge pressure compared to the CBP. So these are the different marks where we can get these waves, different waves. So when we are at 20 to 25 centimeter, we will have the waveform of the right atrium. At around 30 to 35 centimeter, we will get the right ventricle waveform. At 40 to 45, we will get the pulmonary artery pressure waveform, and at 45 to 55 centimeter, we will get the wedge pressure. But this distance can vary in patient to patient. But this is very important to avoid the complication. We can show some artifacts in the pulmonary artery pressure waveform during the right ventricular systole because of the excessive catheter motion. We can have some false or artifact in the pulmonary artery pressure waveform when there is a distal migration of the catheter, or there is a balloon is overinflated. So the normal pressure waveform will be lost, but withdrawal of the catheter will revert again to the normal waveform. Now let's look at the intra-aortic balloon pump waveforms. So basically IBP is inserted in the patient having a low cardiac output. It decreases the systolic afterload and increase the coronary perfusion during the diastole. So basically it increases the myocardial oxygen supply and demand ratio. So this is the console of the IBP machine, and we have to look for the ECG trace, RTL trace and the balloon pressure waveform. This is a waveform of the normal arterial pressure in patient with the IBP. So here we can see after a systolic upstroke, when there is a systolic decline at the point of the dicrotic notch where the balloon get inflated, it will increase the diastolic pressure and produce a peak augmented diastolic pressure. Then the diastolic pressure, the end diastolic pressure will be reduced compared to the unassisted beat. The assisted systolic pressure is also lower than that of the non-augmented systolic pressure. If we compare these all waves, ECG, IBP waveform and the balloon pressure waveform, then we can see here at the midpoint of the T wave, it will trigger the balloon inflation, and so and at peak of the R wave, the balloon will deflate. What happened to this wave during the different scenario? If the balloon is inflated early, then the ventricle has to eject against the inflated balloon, and so it will increase the afterload, it will increase the myocardial oxygen demand. It may also induce the premature aortic valve closure and reduce the systolic period, and so the stroke volume and cardiac output will be reduced. If the balloon is inflated late, then there will be low augmented diastolic pressure and the suboptimal coronary perfusion. We can see here the dicrotic notch also, because the balloon is inflated after the aortic valve closure. If the balloon is deflated early, then there will be the diastolic augmentation will be suboptimal coronary perfusion. It will lead to the suboptimal afterload reduction and increase the myocardial oxygen demand. If balloon is deflated late, then it will increase the afterload, and the myocardial oxygen demand will also increase. This is a balloon pressure waveform. Here we can see different component of the balloon pressure waveform. This is a zero baseline. When the balloon get inflated by the helium gas, there is a upstroke of the wave. Then there is the plateau phase, where in this period the balloon will be stay inflated, and during the deflation there will be deflated wave, which is a steep downward trace. Now let's see the variation in the balloon pressure waveform. If there is a bradycardia, the plateau time of the wave will be increased, and it will look like this. In case of the tachycardia, the decrease in the duration of the plateau will shorten the diastolic phase. If the balloon is too small, if patient is hypotensive, if patient has reduced stroke volume, then we will find the balloon pressure like this. The high balloon plateau pressure will be in case of if the balloon is too big for the patient is incredibly hypertensive, balloon is positioned too high in the aorta, or balloon is kinked. If balloon is not properly emptied due to either by the kinking or the IVP malfunctioning, we will get the wave like this. It is a high balloon filling pressure baseline. You can see here. If there is a disconnection of the helium tubing or balloon rupture, the baseline will be reduced. There will be a sudden fall in the balloon filling pressure baseline. So this is all about the hemodynamic waveform we encounter during our day-to-day professional life. Thank you for your attention.